Hello and welcome to my channel. My name's Peter Abraham. I'm a second career registered nurse focused in the areas of advanced illnesses, specifically those that would either qualify for palliative care or hospice care. Those are two separate types of services. I'm a certified end-of-life doula through the International Doula Life Movement, an avid writer having published well over 500 healthcare articles, an avid book author having written 21 books for hospice nurses, 24 for caregivers, 5 for holistic nurses, and 6 for my fellow end-of-life doulas. If you're new to this channel, welcome. Thank you so much for taking the time to visit. In this channel, we talk about issues related to death and dying. After all, we are all going to die. Wouldn't it be better if we understood what that natural process looks like so that we're not afraid? I have video discussions for my fellow hospice nurses. That's going to be part of today's topic. For my fellow holistic nurses, for patients, families, caregivers, my fellow end-of-life practitioners, typically doulas. If these are topics of interest, please consider subscribing, hitting the bell notification below. I try to publish videos every Monday, Wednesday, and Friday. Sometimes there'll be additional videos either on those days or others. They might be something I believe is important, or a gardening update or a house project update. And by the way, if you like what you're seeing, please do like it. It helps the YouTube algorithm get the message out there. I am not monetized. This is not about getting monetized. Maybe one day, who knows? It's more about getting the message out. So before I go on to the topic of today's video, which is for my fellow hospice nurses, and it would also apply to holistic nurses, predominantly a lot of what you're going to see on the screen today is end of life symptomology, but again, it might fit my holistic nurses as well. I want to ask you, what are you grateful for? In this field, I am asked on a regular basis. I see it in various social media venues. I get asked in person, how can you do this? You're dealing with death either day in or day out, or on a regular basis compared to the everyday person. How can you continue to do this? I'd fall apart. And to me, it's part of the answer, only part, it's a big part for me, is consistently, habitually building resilience. I believe resilience is 3 pillars. If you're, what are the 3 pillars? Ask in the comments below, non-judgmental channel. But I believe the third pillar, which is what gratitude is part of, is asking, what are you grateful for? What are you grateful for? So I typically, more often than not, film my videos in advance of when I put them out there to be published on YouTube, just being transparent. So this is Saturday, October 24th, 2025. I'm probably going to be published this in early November, not too far away. But I'm thankful for my wife, Laura. She's part of the dedication for every single book that I write. We were out there this morning watering she took care of watering certain sections of our garden. I was watering our fruit trees. We're now up to 4. That's still small. We have 2 different types of apple trees and 2 different types of pear trees. And she took care of the carrots and the blackberries. And we also have kale and broccoli, but they don't need to be watered as often. So I'm just thankful that we work as a team, and she's been there in and out through all the different journeys since we've been married. I was teasing her, next year is going to be 25 years in marriage. We moved to Kentucky. Should we renew our vows? She says no. Anyway, I'm so grateful for her. I'm grateful for you taking the time to come here and visit. I'm grateful for everyone who buys and reads my books. Tamara Upshaw, I think she's bought every book I've ever written. It's the, you and others like you who buy my books allow me to operate Compassion Crossing LLC on a sliding scale. I do a lot of work for free because Kentucky has a lot of people in poverty. And so I want to continue to be able to do that. So when you and others buy my books, and I do have links below, if you scroll down in the description, I'll give my different book series. or you donate, buy a cup of coffee. You're not really buying me a cup of coffee. I rarely go out. I'm the geeky nerd, the introvert. But I take that money and then I apply it to be able to provide these services to those in need. So I appreciate. We're not a nonprofit yet, just for full transparency. Compassion Crossing LLC is not a 501 or 503 or whatever. I sometimes forget the actual wording, but we're not a nonprofit, but I do sliding scale. So moving on to the topic of today's video, and those of any of you who I've taken classes with, or maybe we've had breakfast, lunch, if you're local, you might say, Peter is among the most organized persons you ever met. I need to put a disclaimer on that. Organized electronically. Physically, I tend to be a mess. Just putting out there, my wife would use other words. I love her dearly. But electronically, I tend to be very organized. And what what we're going to be talking about today for my fellow hospices, is what you're seeing is not a product for sale, but I want to answer a question that one of my fellow doula classmates asked. She's a hospice nurse, Montana, and she's a wonderful nurse. Any nurse or practitioner, regardless of what the title may be, who says, I had a hard case, what would I do differently next time? They ask introspective questions. That proves that they're blooming. That proves that they're good at what they do because they want to do better next time. So Montana, I appreciate you both as a classmate and as a fellow nurse. So she asked a question about she had the worst case of terminal restlessness she's ever had. And I want to dig into deeper into what I've done in the past with the transparency that my hospice work is from Pennsylvania, just being transparent. But one of the things that I've been developing ongoing over the years, this is literally 2 years in process, is a disease and symptom management database where I have symptoms, what's the disease process that can cause a symptom. Sometimes it's one, sometimes it's several. What drugs, mainly from talking about class, are helpful? What supplements are helpful? Not everything is handled by a pharmaceutical medication. So what are helpful supplements? Either by class, because probiotics is an entire group, prebiotics is an entire group, or by particular, like ginger root. Uh, it's not just disease processes that can cause the symptoms. Drugs can cause symptoms too. Supplements are not an answer to everything. Supplements can cause issues too. Also, dietary choices can cause issues too. And then there's also helpful dietary. Again, if you don't see something filled in, it may not apply, or I haven't figured it out yet, so on and so forth. But I want to I wanted to start at the top just to see how far I've gotten over the years. And by the way, again, this is in progress. This is my private work. I'm not selling it. I'm not looking for your money, donations or otherwise. If you want to ask Peter, I have this person who has this. Can you look it up in your system and tell me what's available? Please ask. I'll see what I can do with the understanding I'm not giving medical advice. I'm providing education, entertainment purposes. Although for my purpose, because I'm autistic, to me, this is not entertaining. This is informational. But you know, all the disclaimers and everything else that we have in our litigious society. So I have a lot on here, if you haven't noticed, by the way. And I want to just get down into terminal restlessness, which is where we're heading. And again, with the nausea, there's a lot of help. I shouldn't say there's a lot of drugs and supplements that can cause nausea. You have to be careful with that. Um, just a reminder for my fellow nurses, nausea. I still remember my anatomy professor, and in all honesty, I don't remember her name. I can picture her face, her like if I saw her on the street, I know you, but I can't remember her name. But one of the things that she would joke about dry sense of humor. I appreciate dry humor because that's my type of humor. She would say, you know, we're like walking hot dogs on a stick, the human body. We have this tube that up here, you know, our esophagus, and I might not get all the words correct, but we have this tube just coming here, going in, becomes our big, you know, large colon, small intestines, it becomes our anus at the end. And it's just, takes different shapes and forms, but it's one long tube. So if any portion of that tube, typically at the lower end, but it could be any portion of that tube gets obstructed, you could have nausea. What goes in has to come out. And if it's not coming out your anus, your penis, it's going to come out via other means. So I share that for my fellow practitioners because if you're scratching your head, you know, is it caused by this disease process? Is it caused by this drug? Is it caused by this supplement? Is it caused by this dietary item? Could be an obstruction. Think about that, and then work on a solution if it is solvable. Not everything's solvable, especially at end of life. We have to focus on comfort. So we're working. I will come back. Okay, we're terminal restlessness. So let me come in here. I'm going to open this up and I'm going to expand it out. And then again, disease process, end of life in general, helpful drugs, first generation of antipsychotics, the atypical, your benzodiazepines, your opioids, helpful supplements, lavender oil, wild orange essential oil. It can be caused if you got too much vitamin B1. I'm not saying that vitamin B1 by itself, oh, stop it, because it's a very helpful supplement. But here, this is where I want to get into for Montana's worst case scenario. And so that you are aware of the intended outcome when I was involved with these cocktails. When we talk about cocktail, when I don't drink often. I'm not, and just to be very clear, I'm not saying I'm a follower of Christ Jesus. There are some who will say, don't drink ever. I believe moderation is acceptable. I'm not trying to preach to anybody, but I rarely drink. So when you just go to a bar or a restaurant, you say, I want this cocktail or mocktail or whatever words you use, they're taking these and they're mixing the different components into one container, whether it be a shot glass or other type of glass, and then whether you're sipping on it or taking it down, that's a cocktail. When we're talking here in terms of a cocktail, like this severe respiratory cocktail, we're not talking about getting a shot glass. I'm not saying you couldn't, depending on the person's ability to deal with the volume of fluid coming in. But these are typically individual 1 ml syringes that have a certain volume in the syringe, and you're giving them one after the other. And under normal circumstances, and I've not had a case in multiple years of hospice where it wasn't normal. I'm just putting out there, I don't know it all, and maybe there's going to be a situation where the order matters. But in my case, it doesn't. So most of these cocktails, when I give what you're seeing here, the intended effect is to resolve as quickly as possible. Don't let it linger. Resolve as quickly as possible with a strong potential that you're going to put the patient into a powder sedated state. You're going to induce a medical coma. I want to be very clear. The intended result for this particular cocktail, and I'm not saying it works for every individual at every time, and we'll go over roadblocks in a moment. The intended effect is resolve terminal restlessness as quickly as possible. We'll go over the why in a few moments, and induce a medically induced coma, powder sedation. So, a couple issues. Let me, for my fellow nurses, first and foremost, in the group that Montana asked this question, when I shared, and I didn't go over this particular answer, I typically start with morphine and Haldol. A fellow person, and I didn't look them up because this is not about titles, this is about collaboration, this is not about who knows what better. It's about collaboration, a village, a brainstorming session. But she asked, and it was a valid question. She goes, the way that you're wording it, Peter, does this mean you're a medical doctor or nurse practitioner? It was a very valid question. I said no. And the reason, and just so you are aware, the reason it's a valid question, when I started off in cardiology, I'm wearing my Harrisburg Area Community College sweatshirts. It's been a couple cold days in Kentucky. This is for nursing. So here, Harrisburg Area Community College. I started off at Harrisburg Hospital, 7th floor cardiology unit. Your first year, maybe even 2 years of nursing, it's very rare for the nurses to do a SBAR. They'll do the SBA, situation background assessment, and it's a teaching in a magnet hospital, and they'll go to doctor. What do you want us to do? They're not actually doing the recommendation part. And I found that odd when I got into practice because we're taught SBAR in nursing school. But I get to Harrisburg Area Community College, and what I'm finding out from my fellow nurses, you do it when you get to a comfort level. So I just want to put it out there. It's okay to do the SBA, but at some point in time, you should be comfortable enough to be able to tell the doctor your recommendation. You may have some doctors, and Peter, what would you recommend? And that's a good thing. So then I went into hospice, and in hospice, especially, I cannot emphasize this enough. If you're good at it, the doctors are expecting you to. And even if you're not comfortable, the doctors, most are expecting you to. Now, I'll give a disclaimer. I've had fellow hospice practitioners who were very much like me when I started at Harrisburg Area Community College. They were like, I am not there yet with a comfort perspective. Then when I took a break for COVID-19 and I worked at Manicare Kingston Court, we had close to 100% recovery because they did early detection, early treatment. This is before Operation Warp Speed and the harmful injectable products that did not work. We had close to 100%. Even then, I still remember my mentors telling me none of the doctors here want SBAR, they want SBA. If they want your opinion, and that's how I was told, your opinion, they'd ask for it. I still did SBAR. I still did situation background assessment recommendation because you know what? At that point in my career, I was a nurse for many years. I know what I'm talking about. I know what I'm asking for. And yes, this is what I want for the patient situation. Now, if they want to override me, they're the doctor or the nurse practitioner. That's their right. And if I agree with them, I'm going through and just so you know, when I say it that way, the majority of the time I agreed with them. But I still remember the one case where they wanted me to do IV push Lasix where the blood pressure was already under 70 and the person was dying. And I told them, no, we have that right as a nurse. So, but here I shared with the person who asked this valid question. No, I'm not a medical doctor. I'm not a nurse practitioner, but I am an experienced registered nurse, and it's within my scope of practice to do the complete SBAR. This is what I want. This is what I need. This is what I know the patient needs. And so that you are aware, because I like being transparent. Where did you come up with this? The initial cocktail, I can't say was my SBAR. This initial cocktail was Dr. Eric Barr. He is the owner of Family Medical Practice in York. He is a amazing medical director and practitioner. I don't have it memorized, MD, DO, etc. But he came up with this for a patient who had esophageal cancer, whose airway did collapse. Ended up giving 160 milligrams of morphine. Roxanol is that liquid morphine, in case you're not sure. 8 milligrams of haloperidol lactate, Haldol for short. 4 milligrams of Ativan, which is lorazepam, the generic term, within a 1 to 2 hour period. And then my patient, with him, most doctors, just so that you're aware, I don't know how to word this because I'm not trying to demean or smack somebody down, they typically don't like write down and put it in a logbook and look it up later on. Dr. Barr didn't remember. I reminded Dr. Barr. Not only for KS, I had other cases where, Dr. Barr, do you remember so and so that we used this? This is the route I'd like to go. And he would say, "Oh, good memory." And by the way, sometimes it's good memory, and sometimes it's because I'm doing stuff like this database system where I could pull it up, because sometimes you don't have. It's not like terminal restlessness is the same severity every single time. Everybody's different. We're going to go why in a few moments, why it needs to be treated in certain cases. Wham, we need it now. So KS, another severe. With KS, I mentioned GM had esophageal cancer, airway collapse. With KS, he had a GI bleed. I forget what cancer he had. I was the in both cases, I was the case manager, but in case of GM, his airway collapsed, and I think it was 30 to 45 minutes away. And when I told my manager, I'm on my way, but I'm 30 to 45 minutes away. We're not EMS. I can't do the siren. I have to obey the law. My manager said she's 15. She's going to get there sooner. So she went. And then I think she actually said, come the next day, she'll take care of it, which I was grateful for. But for KS's situation, and I'm going to do some rabbit trails just to forewarn you. KS is the reason I need to do the rabbit trails is several fold. If you're not, let's say you're my regular viewer and you want to learn how hospice works, you want to learn some of the reality. Tomorrow, I'm actually going to be getting the author copy of the Hospice Journey Handbook that was inspired by Dr. Andy Arari. He's a hospice medical director in Florida, wanted me to write a realistic book. What should families expect for the entire journey through the hospice setting? And so I wrote The Good, the Bad, and the Ugly. And this is in part going to get into the good, the bad, and the ugly. So I still remember this vividly. I was in, oh my word, it begins with an F. Fawn Grove, Pennsylvania. And I was heading from Fawn Grove, Pennsylvania is near the Maryland border. So if you get a Pennsylvania map out and you look at it, Fawn Grove is between Glen Rock, Shrewsbury area on the far east, and Delta on the far southwest. You have southeast, Glen Rock, southwest, Delta before you get outside of Pennsylvania on either side, and down below, just skirting down below is the Maryland border. So I'm in Fawn Grove. I'm heading to Delta. Fawn Grove to Delta was where I was at in Fawn Grove was about a 30 to 40-minute drive to Fawn Grove. I mean, from Fawn Grove to Delta. So I was heading to my patient with Delta. I got a call at that time that my patient in Manchester, so I know we're going to do some geography, my patient in Manchester. So Manchester is an area of York County that's below Harrisburg. Okay, it was an hour drive from Fawn Grove to Manchester. Manchester is not the top of York County. There's still an area on top, and I apologize. It's not coming to me what's up for right now. I guess November is going to be a year here in Kentucky. So I'm already rerouting. I need to have a crisis in Manchester. I'm rerouting, and that's not chaos. This is part of the story. So I'm rerouting. I call the family. I'm on my way. I'm an hour out. I work through what their needs are on the phone while I'm driving. I have, hands free, so I'm doing this safely. And as I'm now driving to Manchester, an hour drive, I get a call from KS's family. I believe it was colon cancer, if memories coming back. GI bleed, severe terminal restlessness. And I get a call. And he happens to be in the Clay. It's in Red Line area. It's about a 30 to 45-minute drive northwest of Manchester. Um, he's in crisis. And so, by the way, my fellow hospice nurses know this is how it rolls. You know, you have scheduled visits, and then you have people that are calling in with crisis, and so you have to do your nursing priority. Now, in this case, I already committed, and I was able to manage the nursing priority system by phone calls and directions and getting okays. Proper communication matters. But in terms of families, if you're a family member watching this, if you're a caregiver watching this, a potential hospice patient watching this, be aware hospice is not on site 24/7 at your location. In rural hospice, we're driving from place to place, and we're not EMS. I don't have like a thing I could put on the top of the car and sirens and lights and just to, ignore the rules of the road. And sometimes there's no roads to get to where places are. So here with KS going through crisis, I had them give the prescribed doses that were available from the comfort kit. So I had to give them, give the morphine. And I remember KS, that this was when I was at a Saracare Hospice of York, PA. I don't remember if this was when they were Golden Living or Medicis. That part I don't remember. But at that point in time, a Saracare's comfort kit was 5 milligrams of morphine every 2 hours is needed. 0.25 milligrams of lorazepam every 6 hours is needed. And I'd have to double check. I'm weak on the haloperidol, whether it was 0.5 or 1 milligram I know it was every 6, but I had them give one of everything, and then I'm going to check with them in 15 to 30 minutes. And so I'm driving, and as I'm driving, I'm trying to keep not only my eye on the road, but my eye on the clock. And when I called them back, because I told them, I said, I'm on my way to Manchester. If this is how we're going to handle things. This is what I'm going to do, and I'm going to give you a call back. And then if it doesn't work, I'm going to call the medical director, and we're going to work together as we're on the phone. But there's going to come a point in time when I get to Manchester, and I'm going to be out of touch for about a half hour to an hour. And then I'm going to touch base again, and I'm going to be immediately coming to them from Manchester. And so I call back, and all honesty, I don't know it was 15 minutes or half hour. No, it was not too much later. I'm that weird person that to me to be on time is either to be early or no later than a minute or two before you said, or you're pushing it if it's exactly on time. Don't be late. Late is anything after. So I call back. It didn't work. Worst case of terminal restlessness didn't work. I called Dr. Barr. He gave me permission. He gave me a loading dose for the Haldol, and I think the loading, going from memory, I believe the loading dose was 5 milligrams, and then here's what we're going through. 20 milligrams of morphine every 8 minutes. Oh, sorry, I have it right here. What the bolus is, 8 milligrams. I don't know how many ml. I'd have to look up the dosage calculation. The 0.5 milligrams of lorazepam, and do this every 15 minutes. Every 15 minutes. And so over the course of 3 hours, this person got 150 milligrams of liquid morphine, naroxenol, 8 milligrams of Haldol. He only needed the one bolus, 1 milligram of Ativan. And then RK also had. Um, and I do have to give you a huge apology here. I should have, this is unscripted. It was RK with the bowel obstruction and the GI bleeding versus KS. But it's the same concept, for the cocktail. So here, as I'm calling, here I call Dr. Barr, call the patient back. All the meds are in places. Why it's so important for comfort meds to be on site the day of admission, no later than the day after. And so I called Dr. Barr, call the family. And this happened one more call before I got to Manchester, one more adjustment. I do my visit in Manchester that I call, and they said it's starting to work. I'm on my way. And by the time I got there, um, it worked. It worked. It worked. And I might be fluctuating here, whether it was KS or RK, because I'm just, yeah, it was. I don't know. I'm still struggling with the memory as to whether it was KS or RK, because I do know with the round trip, like an hour to Manchester, I believe it was on site for close to an hour with the Manchester, and then 30 to 45 minutes. It could have been the 3 hour one with KS, or it could have been longer with if it was RK. But the bottom line, number one, the patient's families, caregivers, sometimes it can take us 3 to 4 hours to get to you when you're in crisis. I'm pausing. It can take 3 to 4 hours in crisis. But here, and to me, I am biased because I'm the one who is part of this. A good hospice nurse, when they're able, will call you as often as they can so that you're aware. Typically, that's no more frequently than 15 to 30 minutes because most medications, the liquid ones, take 15 to 30 minutes for it to work. So you have to give time for it to work. If we call too soon, we might be we might be snowing them, we might be going overboard, we might not have all the facts. So so be aware of that. But a good nurse will communicate, stay in touch, let you know what's going on. And for Montana, sometimes, if you have severe terminal restlessness, let me, before I go back to Montana, I apologize. Why this hard? Why this heavy hitting? I cannot emphasize a couple points enough. It's in my book, the Hospice Journey book. In the last year of life, and I know hospice is 6 months or less, but I want to be very clear. I'm picking an hour. I'm picking a year. The last year of life, any type of discomfort, is equivalent to pain. Somebody says they're short of breath, equate it to pain. If they're uncomfortable, equate it to pain. The reason that I do it that way is I cannot tell you how many families have said, I didn't give the morphine because they said it was only for pain. I didn't give the morphine because they said it was only for pain. Please give the morphine for any type of discomfort. And if you're not sure, call your hospice provider. They should be available 24/7. But terminal restlessness, if you've not heard of what terminal restlessness is, number one, I apologize if I didn't get to it soon enough, but terminal restlessness, it doesn't happen to everyone, but it's extremely common in the last period of life. There's two stages to the dying process. There's the transitioning stage, that's the first stage or phase, and then there's the active dying stage or phase. Take your pick, phase, stage, tomato. So terminal restlessness appears in the transitioning phase. It typically happens towards the end of the transitioning phase. If it is not properly managed and handled as quickly as humanly possible, it prolongs the transitioning phase. I'm pausing to let it sink in. My fellow hospice nurses, the terminal restlessness is late. Whereas we have a lot of different signs as to how long, when we talk about prognosing people, how much longer do they have to live? And I believe every hospice nurse, particularly, and this is every nurse, but particularly my registered nurses, you should know how to prognose. You should be able to tell the family whether they have 1 week, 2 weeks, 3 weeks. And I'm not talking play God. None of us are God. I'm talking learn the signs and the symptoms. There's early signs like pinning of the ears where my earlobes are like right here. You may not be able to see the space, but pinning as if you had an earring in, pinning right to the back of the neck. Pinning is an early sign. Pinning is an early sign. For some people, it might be middle of the road, but it's not a late sign. The gurgle, death rattle, if they do not have congestive heart failure, is an extremely late sign, to the point where for many practitioners will say, if they've not had, trouble breathing, there's no I shouldn't say they've not had trouble, they have congestive heart failure, they don't have pulmonary hypertension, where they could potentially get the death rattle at the middle of the road, will say, hey, we're now looking seconds to minutes to hours. We're at the tail end of the road. Well, terminal restlessness is a late sign, When properly managed, it will typically pass within a few days of the terminal restlessness, or less. So the reason I bring this up is mainly at institutions like skilled nursing, assisted living, personal care homes, where you have a lot of nursing staff. And in the hospice end of life group, there was a 20-year veteran ICU nurse. They weren't a hospice nurse, but they had their loved one at a hospital and they were dying. And the hospital staff were afraid to follow the recommendations of hospice. And I'm using particular words on purpose, because they were fighting with that ICU nurse that was a family member who was properly advocating for their loved one. They need to have the right meds at the right frequency. They were saying, well, we're worried about respiratory suppression for somebody who's dying. Like, seriously, they are dying. Keep them comfortable. Get out of your box. This is not your journey. This is their journey. Keep them comfortable. So this person was properly advocating for doing the right thing, not trying to kill them, not trying to euthanize them, but to keep them comfortable. But the hospital staff were saying, we got to worry about respiratory depression, we got to worry about blood pressure dropping too much, and other things that I've seen happen as well. So I've seen people that family members saying, why are they this way, suffering? Terminal restlessness is suffering. Why are they suffering for 2 or 3 weeks? Because we're having the facility who's balking at getting the orders in place. So if they're suffering, this is where for me, if they're suffering, I want to handle quickly. Now, so that you are full disclosure, I don't recommend this cocktail for every case of terminal restlessness. Most cases, the overwhelming majority, 99%, I am going to be going to the family. We're going to follow the comfort kit regime. But instead of being as needed, listen to me, fellow nurses, instead of being as needed, we're now going to come up with a schedule, because it is not comfortable. Now, for home patients, I do tell them, if at any point in time you want to back off, back off. For facilities, we have to get brand new orders in place. All of my fellow nurses know what that process looks like. And so that you are aware, and this is beyond critical, the patient, the power of attorney, the family are in charge, not me, not you, not the hospice provider. Get the picture. Patient autonomy matters all the time. Consistency matters all the time. So when I bring this up, I ask the powers that be. If it's the patient, I'm asking the power of attorney. If a family does not have a designated power of attorney, I'm asking the family spokesperson. If they tell me they have to get back to me, I stress the urgency of it, but I don't pull the wool over their eyes and start doing something without permission. I'm being very clear. This is something that requires everyone to buy in the equation, because otherwise you're setting yourself up so for you, the practitioner, you the nurse, your team, for so much pain. Don't go there. Obey ethics, morality, etc. So under normal circumstances, I'm saying, okay, what are the directions for the comfort kit? I don't know in 2025 what a Sarah Cares comfort kit was. But from memory, back when I was there, it was, the 5 milligrams of the morphine, 0.25 milligrams of lorazepam, and I think it was 0.5 milligrams of the haloperidol. Lorazepam, haloperidol was every 6 hours, morphine every 2 as needed. But what we would do with terminal restlessness with family permission, POA permission, let's do this on a schedule. And for my fellow nurses, when we talk about the Qs, the Q means every, Q1 every 1 hour, Q6 every 6 hours. We talk about the Qs. You alternate the Haldol and the lorazepam. I love the hospice agencies that give many tools in our tool chest. When I still remember working with Grain Hospice, the plus side, they had higher doses. It was 10 milligrams of, morphine every 2 hours. It was 0.5 milligrams of lorazepam every 4. I loved the higher doses. I did not like that they didn't include haloperidol lactate as part of the comfort kit. I like having all three because you have times that benzo is not going to be the answer to paradoxical reaction. You have times that you can't do Haldol. And again, if you're the admitting nurse and you find out what you cannot use in advance, you've ensured that it's a genuine allergy, ensured it's a genuine contradiction, don't include it. Ask them, please don't bring it in. And then bring it in later in case of emergency and you find out you're wrong. And I don't say that to pounce. But talk about doing a schedule. I like the schedule because if you miss a dose, and getting back to the rotation, it would be like if you're giving the Haldol at 12 noon, so it'd be 12, 6, 12 again. I would give the lorazepam, the Ativan. You give the Haldol at 12 noon, I'm going to give the lorazepam at 3 p.m. So it'd be 3 p.m., 9 p.m., and you'd be alternating the doses. So every 3 hours, they're either getting haloperidol or lorazepam. Every 2 hours, they're getting the morphine. And my fellow end-of-life duelists, my fellow end-of-life, whoever you are for title, if they're still restless. This is just like if they're still in pain, you need to adjust the dose. I still remember my Ohio family that I helped remotely as a end-of-life doula. I was not their hospice nurse, I was their end-of-life doula, but because I'm a nurse, I can still do the S-bar. Just so that you know, they're not the prescriber. They have to go to the hospice, but I could tell them what to tell the hospice provider. So I was sharing that, their loved one was still terminal restlessness after the doses they were getting. And they got to the point where they were giving 10 milligrams, I'm sorry, it was 15 milligrams of morphine every hour. So fellow end-of-life people out there, if you're there and they're giving the meds and the family's saying, we have to advocate. And very critical for my families, my caregivers, my powers of attorney, my fellow end-of-life doulas, social workers, etc. I have had families tell me, so that this is hearsay, grain of salt. I've had families tell me that when they went to the hospice provider, the meds are not working, their loved one is still restless. The hospice, whoever at the other end said, that's part of the picture. Terminal restlessness is part of natural dying. However, it can and should be managed. And if you're a provider, please don't you dare go there saying that, just deal with it. This is the best we can do. Wrong. You can induce a medical coma. You can powder sedate. It is legal in all 50 states of the United States of America. You could do this to keep them comfortable. You may have to get it on the edge of your comfort zone and step out of your comfort zone. We're not trying to kill them with these doses. We're not trying to kill anyone. We're trying to make them comfortable. And if we get them comfortable, yes, they may, and just to be all transparency, they may never wake up. If we do the medical induced coma, they may never wake up. They may never wake up. And if they're in this state, you can't feed them. You can't give them liquid to drink. You can't give them food to eat. Doesn't matter whether they have their gag reflex or not. You cannot give them food or water. That's hard. You have to know that in advance of making these decisions so that you can make full informed consent. But be that person. Be that person. Uh, this is it for this video. I do thank you for your time. If you have any questions, comment down below. If you want to see future videos about this or that, comment below. I do appreciate your time. Thank you.